We're going to start with sort of the complications of diabetes, and one of the important issues is the issues of screening. So let's just start with a question. 19-year-old female has a 1-year history of type 1 diabetes, type 1. Which of the following statements is true regarding her evaluation? A, she should be referred to an ophthalmologist to screen for diabetic retinopathy. B, she should have a urine screen for albumin. C, she should have screening lipids. D, she should have a creatinine clearance. E, she should have all of the above. These are general ADA guidelines and other guidelines that have been put out. What is your answer, please? Whereas I recognize that many of you may do all of the above for cost-effective reasons with new onset type 1 diabetes, she does not need screening for retinopathy. She does not need screening for urine albumin, and from the point of view of diabetes alone, she does not need screening for creatinine clearance. However, because she may be at risk for coronary disease, because you may want to start management therapy beyond glucose and blood pressure, the general guidelines do say she should have a lipid profile. Appreciate your aggressiveness, but if we take out of your salary everything that's unnecessary, it may change your approach. 59-year-old white female with a 1-year history of type 2 diabetes. Type 2 diabetes, which of the following statements is true? And it's essentially the same list at the top. Ophthalmologist for diabetic retinopathy, screen for albumin, she should have screening lipids, she should have monofilament foot testing, or she should have all of the above. If I may have your answer, please. Good. 1/3 of the 20 million people in this country with type 2 diabetes don't know they have it. They may have had it for many years, so you have to start screening for all of the complications. Which of the following statements is true about the relationships of glucose control and the complications of diabetes? This kind of looks like an Addie Meta question, doesn't it? A little more complex. Mechanisms by which glucose may contribute to complications include protein glycation, sorbitol accumulation, or activation of protein kinase C. B, in tightly controlled patients whose hemoglobin A1Cs increase, the effective control are lost within 2 years. C, large clinical trials have shown that glycemic control reduces coronary heart disease risk as much as lipid lowering. D, insulin treatment reduces the risk for microvascular complications but increases the risk for coronary disease. E, type 1 diabetes has a 1% reduction in hemoglobin A1C results in a 25% reduction in retinopathy and nephropathy, while in type 2 diabetes, the same reduction results in a less than 10% reduction in these complications. If I may have your answer, which of these is true? Good. Most of you got it right. Let me just go through this. We do not know the exact mechanism by which glucose causes complications, and all of these have been invoked as potential mechanisms. A lot of interest now in PKC inhibition, for example, for retinopathy, although PKC may be activated by hyperglycemia. I will show you the data that demonstrates that B is wrong, that the effects of tight glycemic control are actually durable for 8 years, whereas theoretically we expected it to be lost in 2 years, it's not. C, large clinical trials have not shown very much of an effect on glycemic control and coronary heart disease risk, whereas a number of trials in the lipids arena have shown favorable effects. Insulin treatment reduces the risk for microvascular complications, and if anything, a modest reduction in risk for coronary disease. Dr. Zimmerman didn't amplify that, but he did show you the UK-PDS data. And then finally, for both type 1 and type 2 diabetes, a 1% reduction in hemoglobin A1C gets you about a 25 to 35% reduction in microvascular complications, and it's true for both type 1 and type 2 diabetes. So if we're going to screen, I've already talked about the fact that we should screen at baseline for all of the complications in type 2 diabetes. This is sort of affirming what we asked with regard to the questions. Let's talk a little bit about diabetic retinopathy. It has been known since the results of the DCCT came out. Maybe I should ask the question first. Which of the following is not true regarding diabetic retinopathy? We're not allowed to ask this sort of question in our medical school, but we can here, okay? Glycemic control predicts the risk for onset of diabetic retinopathy. Glycemic control predicts the risk for progression of diabetic retinopathy. Laser therapy reduces the risk of visual loss. Office ophthalmoscopy is adequate for detection of significant retinopathy, or all of the above, meaning they'd all be false. Which one is not true? If I may have your answer, please. Okay, most of you got it right. Glycemic control clearly reduces the risk, predicts the risk for retinopathy. And of interest, the DCCT tried to answer the question, will it reduce the risk for progression of retinopathy, based on some dog data that suggested once diabetes was set in place, if you initiated tight control 2.5 years later, you did not slow the progression. It was sort of like once the die was cast, it was cast forever.